Okay, we are back again with another clinical conversation with Dr. Ken Cooper, the lead instructor at Master Dry Needling, and we have Ashley Langford again with us, Director of Clinical Excellence at the CORA Institute for Clinical Excellence, and I'm Adam Goodrich with the CORA marketing team, and we are talking with Dr. Ken Cooper today about dry needling. Ken teaches a lot of courses, especially supporting us at CORA, and this conversation is going to be a little bit more for the clinical audience. So I would say the clinician may be interested in pursuing a dry needling certification. You guys can help me unwrap that a little bit. But yeah, I want to dive into some of the things that somebody should know if they're coming out of school, or if they've been out of school for a little bit and they're thinking about getting dry needling. Do they need to? Should they? When should they? Where should they? Why should they? Let's dive into all of those questions. If you can remember them all, let's start hammering at them, Ken.
Oh, that's a great way to start, actually. I was just teaching at CORA in St. Louis last weekend, and we were talking about this very thing. So one of the things that has really fed dry needling clinicians and pushed patients into requesting it. When I started dry needling 33 years ago, no one even knew what it was. But now patients are actually doing Google searches because they have heard how much it helps, number one. Secondly, their physicians are not prescribing opioids like they used to. The Vicodin prescriptions have gone down. The cortisone prescriptions have gone down. The pain meds have gone down a lot, significantly. And the very, very cool thing about dry needling, and the research supports it, is that you can stimulate the body to release its own opiates, its own endogenous opiates that the body already manufactures. So I'll tell my patients, you have a pharmacy inside your body. You just need some help to get it released. And so I'm sorry your doc wouldn't write you a pain pill prescription, but I can give you one. Let me talk to you about dry needling. So that's what I will say to the new graduates. You're going to have a so much easier time getting patients because it seems like everybody wants to find a dry needling clinician.
Man, he can sell it.
I'm in. Okay, and talk to me about the training component of it. If I decide I'm going to pursue it, is it a one-day thing, 2-day thing, week thing, month thing?
Yeah, so most seminars you go to, including ours, are the introductory seminar is a 3-day seminar. It's 27 hours because there's a lot of anatomy to review. We're all pretty good at anatomy in our field, but 3D anatomy we haven't had to be good at. We were really good at during cadaver dissection, right, when we went through training. But after that, most of our anatomy training we don't think of it in 3 dimensions. For example, like a radiologist would reading an MRI report. He has to look at all the different slices of images that he's looking at. So we have to review the 3D anatomy to know what tissues the needle is going through on the way to the target, review where the danger zones are, where we won't hit nerves, we won't hit arteries, we won't hit major veins, and we won't hit organs, of course. So there's a lot of safety precautions that we heavily emphasize because we as clinicians haven't had something in our hands that could injure an organ before, right? And now we have something that could actually puncture a lung or puncture a bladder or puncture an intestine. So 3 days for an introductory course is pretty much standard across the field for that reason. And we teach, there are different courses or seminar companies handle it differently. We teach a 3-day introductory class. Then we teach an advanced class, which is the one I taught in St. Louis at CORA last weekend, which we call our level 2. And then we offer a certification in dry needling. So it's a total of 54 hours of training before we certify.
And correct me if I'm wrong too, Ken, but different states have different requirements. And the nice lay out with master dry needling is the fact that if you're in a state where you can start practicing after the intro, you've got the resources to treat versus just specific body parts. Is that right?
That's totally right. So when we decided to bring dry needling to the market through Master Dry Needling, we designed the introductory course, the first 3 days, to equip a clinician to treat probably close to 75 to 80% of the people that come in, at least with basic techniques that would be very safe. And so the states that say, so long as you show some training, we know your background and education is high quality, and go for it. So we set up our introductory class to equip that clinician.
Is that, I guess, what about like the like is your philosophy different than other organizations you mentioned, or what are some of the differences in maybe the philosophies between Master Dry Needling and other courses?
That's a great question. So I was trained in dry needling differently than all the other instructors in the country, honestly. And it's not anything that I pursued. It's just the way my life turned out. So my ex-wife was very, very, very sick, and I was trying to find help for her and could not find help. She was slowly dying of a mysterious disease. And in my search for clinicians, from physicians to acupuncturists to chiropractors, I went to the medical schools, I went out of the country, I kept looking. I happened upon a German MD, PhD, who is a specialist in autonomic nervous system. And so I took her to him, and he was like the 42nd doctor I had looked for help with her. And he immediately made changes in her. This first time I had seen any changes in 6 years. And so I kind of attached myself to him like Velcro and started he was in Santa Fe at the time. So we would fly to Santa Fe, he would treat her, and then I would follow him in his clinic while she rested at the hotel and would watch him treat patients. And his was an injection technique, and it was designed to balance the autonomic nervous system. And so as I learned from him, I started using balancing the autonomics as part of my dry needling technique. I started out as a dry needler just doing trigger points because I had learned that from Dr. Travell. As you know, she was JFK's doctor, and she made trigger points famous. And the trigger point hypothesis was the only hypothesis for a long time. And so I got her book, and I was needling trigger points. And then when I met Dr. Klinghardt from Germany and saw how he expanded the trigger points, he was an incredible trigger point clinician, but then he balanced autonomics, and he taught me how to use autonomics to guide the treatment and how to look for autonomic signs during the treatment. And what that did was it gave me faster results with my patients, and it lasted longer. So at the time I met him, I had started treating the Dallas Cowboys, and they got enough relief that they started coming in very frequently, and a lot of the players were coming with all kinds of injuries, and I needed something exactly that would work fast and would last longer. And adding in this autonomic focus into the treatment regime really afforded me those two things. And so I kind of expanded my trigger point dry needling practice into a more of an autonomic focus. And so that was kind of the second step that I took. I started out with trigger point needling. Then I added in the autonomic focus, and then another catastrophe happened. I was in a bad wreck, and that's so in my search to get better after that, I was seriously hurt, which is hard for a self-employed healthcare worker, right? I met Tom DeLonzo Baker, and he's a physical therapist in Raleigh, Durham, and he brought the technique of total motion release to the market. He's the technique founder. And so I met him actually over the phone, and I had seen some of this stuff online, and it was almost too good to be true, in my opinion. And so I just called him out of the blue, and I said, I just called the clinic and say, this is Ken Cooper. I'm a chiropractor in Dallas, Texas, and I'm a physical therapist, and could I possibly speak with Tom? Is he there? And they just went and got him, and he got on the phone. He goes, hey, what's up? How can I help you? What's going on? And over the phone, his techniques changed my body literally in about 45 seconds. And it had been 18 months that I had been working with real high level PT orthopedic rehab. And so he taught me total motion release techniques. And that was like the kind of the crowning capstone for me. I added the trigger point, and then I added autonomic, and then I added total motion release. And so master dry needling combines all three of those into one technique.
That's really cool.
That
really,
was a good answer.
Yeah.
Sorry, it's a little bit lengthy, but
well,
that's the story.
I think the autonomic nervous system too, I could be wrong, but I think that the physical therapy profession is probably going to go more and more down the route of trying to better understand the vagus nerve and what we can do to support. I mean, particularly with probably ADHD and anxiety and different things that are probably going to be more and more common. Sure. It's going to be a powerful tool. So not to go too deep down there, but really kind of like what you hit on with that.
Yeah, and well, everything is based on homeostasis. The body always wants to fix itself. We just didn't stop and say, well, how does that work? How does the body fix itself? Well, autonomics are in charge of homeostasis. So anytime we try to speed up healing, the autonomics are kind of the major player. We just didn't really think of it like that in the West, like they did in Germany when I met Dr. Klinghardt.
So let me go back to a question that I think that I may have started with too. If I graduated today from PT school, when's a good time for me to consider pursuing certification?
As soon as the state board lets you. Okay. So some states restrict it and say, no, you have to have 2 years of experience before you can take the class, but you can't treat any patients, right? And so different state boards have different restrictions on the training and implementation of dry needling. But like I said, the 3D anatomy is actually fresher in the mind of a new graduate because of the recent cadaver dissection and the recent education in the halls of the medical school where they're going. So as soon that's the background you need, because safety is really based on anatomy, right? Although we have clinicians that the most excited clinicians, I think, are the ones that have been out for 5 to 10, 15 years, and they keep running into roadblocks with their patients. They say, man, I just need something else in my toolbox. Everything I've been using gets most people well, but those 20%, man, that's really driving me crazy. And that's where needling comes in.
Yeah. Amateur comment here, but like, tennis elbow, I can't even fathom going back prior to dry needling or plantar fasciopathy, or, I wouldn't know how to treat it now.
Yeah, if you took dry needling away, it would be hard. That's true.
Okay, that leads to my next probably two-part question. Do I need to be dry needling certified to kind of be, to draw from our marketing jargon, to be fully optimized? And if I am dry needling certified, do I use it on every patient?
Two good questions, right? So, like I said before, the opioid crisis is pushing people to look just for this. And so all the other talents you have as a clinician, they may never have access to if you aren't dry needle certified. because they are looking for dry needling just because of social media and internet, and the amount of relief that patients are getting are pushing internet searches and social media searches. In my practice in Dallas, I didn't even do much marketing because they would just type in a Google search, who does dry needling in my zip code, right? And so that was the doorway to kind of get them access to the rest of what I knew as well. And so if they came in wanting dry needling, I would nearly invariably give it to them and use it as a tool to introduce them to the other things that I could offer them as a clinician. So I never promised these fantastic results. I never said it cures everything. The thing I promised was that I would do my best with all the skills I had to help them recover from whatever it was they were fighting. But the amount of success that as I became more and more experienced, and as I added these dimensions to my needling practice, I was able to use it in patients that I was, unable to get success with before.
I have a question that goes back to the course, and I think earlier
Okay.
you said that when you take the course, you come out and you can treat 80% of the body or so with dry needling after your introductory course, correct?
Right.
All right. So I imagine what that means is if I'm in the course and Ashley's in the course, he and I are both practicing on each other.
Needling each other.
Yeah. So
and you have to sign a release. Okay.
I imagine just X marks and drawings. I've seen some pictures covering the body with needle pricks everywhere. Is that about right?
That's about right. We we teach it a lot like we did in physical therapy school. You'll have to review topographical anatomy. We use washable markers right on the skin to review pertinent anatomy of the area we're going to needle, and then we practice needling within that drawing. And so, yes, we needle each other just like we learned on each other in physical therapy or chiropractic school. And that's been an effective and safe way. And that helps people that are, say, I don't want to be needled by someone that's never needled before. But guess what? They're going to get needled by you, and you've never needled before. So it works out. We push safety a lot in the courses, and we're there to be sure that nothing goes awry.
I have had the electrical component added to stim, I think, in my multifidine. Does that sound about right at one point in my life? Yes. And
let me ask you a question. How about this? Have you had stimulation otherwise, like with the sticky electrodes on your skin?
I don't think so. No.
Okay.
No,
it's just sometimes a good comparison because it doesn't feel the same as stim that we put on the skin with sticky electrodes, because it goes past the skin down to the target. So did it feel electrical to you when they put the stimulation on the needles?
I would describe it as it feeling weird. It feels like somebody is kind of jumping into the driver's seat of your body in that area and it's like, all right, I got this. Like, trust me, it's all good.
Right. But it wasn't uncomfortable, right?
No, it's fascinating. You have to, it's kind of I guess you would call it an inner body experience instead of an outer body experience, but it really makes you, get in tune with that area. And
sure.
It's
clinicians ask me in the seminar to say, well, when you apply stimulation, you wouldn't do that to someone that's in acute pain, right? Because it would hurt. And that's a common question from the attendees to the seminar. And the truth is it doesn't, right? It's just weird, but it doesn't hurt. It actually helps release those opiates, endogenous opiates that our body has.
To go back to the patches, though, I think after I watched Rocky with Drago and the Russians used the patches to try to build some muscle, I think I did try that once, though. Joking.
Yeah, got it.
Okay, what about like do's and don'ts? If you're if you're a clinician, maybe thinking about getting certified, or if you are a clinician that is certified and listening in, are there like Ken Cooper do's and don'ts of dry needling?
So the one thing that I try to stress to clinicians is this is so powerful. If you're considering getting trained, but you think, I think it would hurt too much, or I think I might hurt somebody. Those are the two biggest fears, is that it might hurt me in the seminar. I'd be so uncomfortable I wouldn't want to be there, or I might go out and damage somebody because I wouldn't have enough experience when I started. I would have to treat that first patient, right? So please don't let that stop you, because we've designed the seminars to specifically address those two fears, right? So I have a lot of people on Sunday that say, man, I feel so much better. I've been so nervous about either hurting myself or hurting a patient. And then if you're already certified and you've thought about taking an advanced class and you haven't, there are so many tools that are available. Like, we don't really teach much craniofacial in our level 1 or hand and foot intrinsics. There's just not enough time in our level 1 course. So you can really double your toolbox by taking an advanced course. And thirdly, we believe any of you guys that are already needling, you know how powerful it is. And we want the referrals from the physicians to multiply, because still my orthopedic friends are still scared of infection, right? They're still hesitant to write some orders, to post-op orders for needling, because they're so concerned about infection. So I do all I can in the seminars to encourage the clinicians to be overzealous in cleaning an area and wearing gloves on both hands, even cleaning an area around the joint capsule with chlorhexidine instead of just alcohol. Just encourage needlers to play by the same rules of cleanliness that their physicians do. If they were, for example, giving an injection, they would never do it just cleaning with alcohol or with just one glove on. So let's just keep all the rules for needles the same to help the referrals start piling in.
Good point. Good point.
Do you think dry needling will ever be a part of the curriculum of PT school?
Absolutely. And it already is in many schools. So it's something I ask in our level 1 courses. You know, if you got it in school, let me know how much you got. And so already some new grads are saying, yes, I got to put one needle in a lab partner one day. And then others are saying, yeah, we had about 6 weeks where I got to do that for about 6 weeks. Some of the clinical rotations, now the clinical instructors are teaching it as part of the clinical experience in the outpatient or hospital setting. So yes, it's coming. It's just kind of slow.
Yeah, I could see Ken Cooper, head of dry needling at Duke University.
I do, bringing that up. So I have a personal goal is that it's a routine inpatient hospital experience for the PT to go to a patient's room or the patient come down and get ultrasound-guided dry needling. And so if we can keep all those cleanliness parameters I was talking about and get the extra training for the ultrasound, there's a group in the New Orleans area that took my class 7 or 8 years ago, and the director of the PT department came up to me on a break and said, I'm going to have all of my physical therapists certified in musculoskeletal ultrasound, and we will be doing it in the hospital. You wait and watch. And I knew no one was doing that. And so I was watching that with bated breath, so to speak. And sure enough, they were the first hospital that they're now called to the emergency room in the hospital for dry needling by the ER docs. And they're called by the orthopedist to say, I don't want to wait on the MRI, just put your magic ultrasound on there and tell me if this is a full thickness tear or not. And so we're seeing these big jumps starting to happen in the field, and that will also get the education at the school level more in depth, I believe.
Wow.
That's cool. Is it ultrasound guided for inpatient? Why ultrasound guided in that scenario and not an outpatient? Just because it's
Yes, well, you can do it in either scenario, of course, but it has kind of made its way into the outpatient realm. But the inpatient realm has been pretty much, it had to be physician run, right?
Yeah.
Or a sonographer do the technique, and then the physician interprets it. And so for a clinician in our population of training, or a physical therapist, to say, no, I'm going to be the one to do it in the inpatient setting, which was a surprise to me. Like you said, I thought it was all physician based inside the hospital as far as ultrasound went.
Yeah.
And I was at Tulane with my friend from New Orleans, taking a musculoskeletal ultrasound class. And the physician said, let me just be honest with you guys. I would rather you do it because I don't make enough money doing the ultrasound. I would rather you do the ultrasound and tell me what needs to be done. And then I'll use my ultrasound and I'll do PRP and I'll make money for both the ultrasound and the PRP, but I wouldn't have had to spend my time doing the ultrasound study.
Interesting.
It was a shock, but I see it slowly changing. The radiologists are going to make better money, honestly, interpreting MRIs, or doing their radiation services in oncology, et cetera. And so it's kind of a way for us to grab this bull by the horns and say, we've got the training, we can make this happen. And so that's kind of what's happening.
All right, before we wrap up, I wanted to say that if somebody is listening and is as fascinated probably as Ashley and I am listening to Dr. Cooper talk, you guys can learn more at masterdryneedling.com. I also just pulled up your Instagram account, which is Master Dry Needling. Ashley, anything else you want to ask or share?
No, I just want to say thank you, Ken, for jumping on. It's been awesome listening in, and for those that are interested in either starting out in dry needling or taking a step further, I was one of those scared to death to get started, and I don't look back at all. It's game changer. So
Excellent.
Go for it.
Yeah.
I really appreciate
anything else you want to share?
Yeah, no, sorry. I just appreciate the chance to visit with you guys.
Yeah. Awesome. Well, this was super informative, and hopefully folks will listen to both parts. I think you're going to learn a lot, either clinical or patient population, from both sessions. So thank you for joining us. This was great. Ashley, thank you. And we are going to wrap this episode up. We'll see you guys soon. Thanks.
Thanks, Adam.